Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
This is Stroke Awareness Month, and do you know the signs of somebody having a stroke? How can you tell? And if someone is having a stroke, what do you do? Timing is the most important thing, and we're going to talk about this tonight. There's actually a phrase that's used in the medical field when it comes to stroke. Time is brain. During the next hour, we have experts talking about all kinds of people that have strokes, not just those who are at high risk, and strategies and treatments that not only help at the time of treatment, but also some prevention measures that we can talk about. This program is underwritten by Tenet, the Hospitals of Providence, and also the El Paso County Medical Society has been bringing the show to you for over 26 years. I'm Catherine Berg. Thanks for tuning in. This is the El Paso Physician. Thank you again for joining us. We are talking about strokes this evening, and we have two doctors with us of different disciplines, but really know everything about the world of strokes, a little bit about neurology, a little bit about internal medicine, and also nursing. So we have Dr. Kenneth Berumen here, who is emergency medicine, but he's also the chief of staff at Sierra Medical Center. And not until just about 5 minutes ago did I realize that he started off as a nurse and graduated from the UTEP School of Nursing.
Correct.
So thank you so much for being here. That's going to be a
Absolutely.
lot of fun talking with you this evening. And then we also have Dr. Vikas Gupta, who is in the world of neurology and also did some internal medicine along the way, some preventative cardiology. So it's going to be a really interesting program. Dr. Berumen, I'd like to start with you. You're in emergency medicine. You said you've been an ER doc since you've become a doctor. Describe your day, if you can. You are also chief of staff.
All right.
And so we're going to leave that at the table for a little while. But your day in the ER, and again, we have so many TV shows that we see about the ER
Sure.
room. Is it like that really? And
The
what is it
ER
that
is
you do?
actually probably the most exciting job I can ever think of. It's you never know what's coming through the door. You have a variety of populations, anywhere from children to 104-year-old people. You just don't know what's coming in. Oftentimes, the patients don't know what's happening to them, so they're trying to explain to you what's going on, and you're trying to decipher that from their clinical stuff, from what they're telling you, from what the family's telling you, and it's kind of a great puzzle, and it's a great way to work your life. I think it's very exciting to be in the emergency department.
High stress. And it was interesting as I asked if you were on call when you walked in. We asked Dr. Gupta. Dr. Gupta is on call, and you said, well, I'm an ER doc. I feel like I'm always on call. Dr. Gupta, let's take things to neurology and the study of what you are doing now. And you've been in El Paso for a whopping 3 years. We were talking about the great food we have in El Paso, but you've been all over the country and studied different things. In your area of neurology and strokes of what we're speaking about tonight, what is it that you do all day, every day?
Sure, Catherine, thank you very much for having me today. And it's a great pleasure to meet Dr. Perriman as well. What I do day to day practice is best described as interventional neurology, something very similar like an interventional cardiologist. So, what I do is interventional treatment of stroke, both ischemic stroke caused by a blood clot in the brain, and also minimally invasive treatment of bleeding kind of a stroke, such as a ruptured brain aneurysm or bleeding caused in the brain from a brain arteriovenous malformation or a fistula in the brain, or, for example, the treatment of carotid disease by placement of a stent or doing angioplasty. So, our work is very similar, just like the cardiologists do heart angiogram. We do what we call a brain angiogram.
Mm-hmm.
The same principle, same philosophy. We put a small catheter in the wrist artery, usually these days, or through the artery in the leg. And a small catheter, the size of a spaghetti, goes from the wrist artery all the way up inside the brain, where the blood clot in the brain is, and we retrieve the blood clot to get the patients suffering from major stroke get better and beyond their life.
Yeah.
And then,
And
yeah.
we'll talk about the two different types of stroke, or at least the two main different types of
Mhm.
strokes, because I know that there's I like doing this particular program because there are two very different treatments depending on what type of the stroke it is. So, what I'd like to do is kind of back up a little bit and talk about, just in general terms, Dr. Bruman, what is happening when someone's having a stroke, and then we'll go into the different types of stroke.
So, stroke essentially means there's not blood flow getting to one part of the brain, whether that be a delivery problem, like the artery is blocked, or whether that be a clot, which is then distally, meaning the blood can't get past that clot, or whether there's some other foreign object in there. The strangest one I saw was a paint gun in the neck, and then it was a paint clot into the brain. So anything that stops the blood flow to the brain that's normal is going to cause a stroke. And it can be a variety of things that causes.
I'm just going to ask you about that later because you can't just say something like a paint gun and then a paint block. That's going to be a conversation that we're going to have.
Sure.
So, if I could talk about ischemic, and I know you mentioned it, and then hemorrhagic, and then at least those two are as I understand it, the two main types of strokes, right?
Correct.
And as an ER doctor, the diagnosis of those. So first, let's talk about the two differences, and then we'll talk about ambulances and who do you call, what do you do exactly. But what is an ischemic stroke?
Ischemic stroke means there's not blood flowing to there. It's usually from a clot or some kind of blockage to that artery that prevents the normal blood flow distally, meaning beyond that area. So that part of the brain is not getting its blood flow, it's not getting its glucose. And time is really the essential component of all of this. You do not want to sit around and saying, hey, something's not right. My face doesn't feel right. My arm doesn't feel right. That's the time where you initiate 911 immediately. I think 911 is the key to all these processes.
Hmm.
So
Agreed.
ischemic means there's something blocking it. Hemorrhagic means the lack of blood flow. So you think about your garden hose, and when you're delivering it to your garden and it's working fine, but now you got a puncture in that hose, and now the water's seeping out to the side. Not the same amount of water is getting to your garden as it is leaking out. So now we have a disruption in the normal blood flow, and that's what the other component of most strokes are.
Okay. So here, and Dr. Gupta, if I'm jumping, because I want to go in an order of diagnosing this. And if you need to throw things again, and this is, we were talking about this. If I'm asking one doc one thing and you want to throw it to the other one, feel free to do that. But if someone, when people are having a stroke, usually the person that is with that other individual is a person that says, okay, you're just not acting right. And I'd like for you to take it from a neurologist's point. How do you know if yourself is having a stroke? It's easier to tell if somebody else is, and maybe describe some of those symptoms that are happening.
Sure, that's an excellent point. The point that you brought about that stroke is most often noticed by the family or the friends around the person that is experiencing the stroke,
Hmm.
because sometimes the person who's experiencing the stroke may not be able to speak. So his ability or her ability to communicate that I'm having weakness on one side of the body or numbness is impaired by her inability or his inability to speak and communicate.
Hmm.
But more often than not, the classic symptoms that the person experiences is sudden onset of weakness or paralysis of one side of the body, arm or leg, or sudden onset of numbness, or sudden onset of lack of vision in one eye or both eyes, or sudden onset of spinning sensation, vertiginous sensation. Obviously, that includes also the inability to speak, etc., and
Hmm.
facial droop. So it's very important for the family members and friends around them. They're often the ones that notice that, oh, the face is droopy, or the
Hmm.
person is not walking right. But from an individual perspective, the common things that are noticeable is that suddenly my arm feels numb or
Hmm.
heavy or weak, or I cannot control it. So loss of coordination, and then the symptoms progress.
And is there pain involved?
That's a very important point, and that's the reason why the stroke gets neglected. Is
Mm.
unlike a heart attack, which gets everybody's attention immediately, the strokes are painless.
Mm.
So people often, if it happens while they're sleeping, or people tend to think that, oh, my arm is numb because I slept in a wrong position. So there is a delay in seeking immediate medical care because of the fact that it's not causing pain.
Hmm. And we're going to talk, and I just thought about it as you were saying it. There's something that people call, oh, I just had a mini stroke. And maybe there's like 4 or 5 mini strokes, but I do want to get to that in a little while. Um, Dr. Baruman, I would like to ask you, when an ambulance is called, like somebody's noticing something's wrong, an ambulance is called, and I know several shows back, we had a firefighter on, chief firefighter on. He was talking about the different stroke units. There's a stroke unit that we have in El Paso, but this in general too, if the stroke unit isn't by you, in general, what are the ambulances equipped with to start some kind of treatment? Because like you said, timing is it. Before I ask that question, because it goes what you were talking earlier before the show, FAST, the word FAST, the acronym, and it's looking for the face. If the face is drooping, arm is not feeling right, it's feeling heavy and or not functioning, speech is off, and then time. So that's something we'll talk about a couple of times to help educate the audience. Just think of the acronym FAST: face, arm, speech, and time. What is it that the ambulances, the emergency vehicles have that might be able to help with diagnosis?
So most of El Paso Fire is equipped with medications, with blood pressure evaluation, and the key is the paramedics and their evaluation. So they do what's called a LAP score, a LAM score. They're going to take an assessment of the patient and see if they really look like it's a real stroke. They'll call in immediately and then they'll transport. The key is the timing to get to a facility where either we're going to take the clot out or we're going to give you something to break up this clot. Now, there is one ambulance in town that UMC has that has a CAT scanner on it. So
Mhm.
we actually have a CAT scanner that runs around the city. It's separated in different parts of the city throughout the town, and they'll be dispatched to strokes. They have an 8-slice CT scan. For the doctors, we know that that's a small thing, but we don't need a huge scanner in these ambulances. All we need to know if there's a bleed or not.
Mm.
And this 8-slice CT on an ambulance will give us a great amount of information whether this is a bleeding stroke or more likely a clot stroke. And that really helps us decide what we're going to do with this patient when they arrive to the department.
And are the symptoms any different from a bleed stroke versus a clot stroke? The symptoms are basically the same as, again, there's not blood getting to the right area of the brain,
Exactly.
correct?
I mean,
Okay.
there can be some differences, but for the most part, it's a lack of ability to do something because of lack of blood flow, whether it's been diverted by a bleed or whether it's been diverted because of a clot.
Okay. So I'm going to keep it with you for a moment. So now we have someone that is getting to the ER. And immediately, yes, definitely the symptoms of a stroke. Now they get into the ER, and where do they go to figure out which kind of a stroke it is? Like, okay,
So what we do is when the ambulance calls us and say they think they have a stroke, we meet them at the ambulance door.
okay,
We get, the registration people get their stuff, but we go straight to a CAT scanner.
great.
So we're going to find out
That
if
is the
if
first place
it's
you go.
correct.
Okay.
We'll put all the stuff in the patient. We'll get their vital signs in the CAT scanner. So again, the key is time. So we're going to get them to the CAT scanner as soon as we can. We want to find out if this is possibly a clot stroke or a bleeding stroke, because that really helps us determine which path we're going to take.
Okay. And I do want to talk later about blood thinners, because that is something, if it is a clot stroke, then that begins your whole life on different things. Dr. Gupta, and it's just so I can kind of ping pong back and forth, but the beginning of the show, a lot of it's like the ER stuff. But once they get to the ER, and let's say it is a clot stroke, what kind of medications are then administered right then and there? Because I understand that there's some that almost immediately, not immediately, but kind of can get the clot to break down. Is that done intravenously? Is that done through the head? And I know you were talking a little bit earlier about getting into the brain.
So
So,
it's a great question, Catherine. Again, for the last 25 years or so, the only FDA-approved medical standard of care for treatment of acute ischemic stroke is the IV TPA,
okay.
which is given within 4.5 hours of patient symptom onset for acute ischemic stroke. So once my colleague, this is Dr. Berryman, looks at the CT scan and there is no evidence of hemorrhage, and we have a working diagnosis of ischemic stroke caused by a blood clot in the brain, so the focus is to administer the IV clot busting medication called the TPA. Now we have a second optional called tenecteplase, which is similar except it's more potent than TPA, and it's given through the IV.
Mm,
So it's given, again, this is a medical standard of care in order to dissolve the clot, and is given within 4.5 hours of symptom onset. So you call it a clot busting medication, either TPA or TNK.
okay. And going back to what you were saying earlier, sometimes strokes are easy to ignore because there is no pain. And let's say that the 4.5 hour time frame is passed. Let's say that somebody was having pains, wasn't feeling good, went to bed, slept through the night, and tomorrow morning they're like, okay, I'm still not feeling right. So let's say 12 hours has passed and it is a clot type of a stroke. Talk us through the difference between getting to someone within 4.5 hours and getting to someone after 12 hours?
So again, great point, a great question, and very common scenario. More often than not, actually, stroke happens just like heart attack before the awakening, like around 6 o'clock in the morning or 5 o'clock in the morning, before the person awakens. So technically, it can start anywhere between the time that the patient went to bed last night and at
Mm,
the time of awakening. So we are in a situation that we don't know the time of onset of stroke symptoms. So the clot busting medication is not indicated. So the way to address those patients with stroke is to do a study called a CT angiography, which defines the exact location of the clot inside the brain. So we confirm that there is indeed a clot and we assess the clot size. And then we put in a small catheter, either through the radial artery, the wrist artery, or through the groin artery. And then that goes all the way inside the brain where the clot is, and we retrieve the clot, which is the endovascular, the minimally invasive treatment option for people who are A, not eligible for IV thrombolytics, or
mhm,
in addition to the IV thrombolytics. The IV thrombolytic success rate is maximum for small clots,
mhm.
but the effectiveness of IV thrombolytics decreases as the clot size and the clot burden increases. So much so that once you have a clot which is about a centimeter or so in size, studies have shown that the clot busting medication has 0% efficacy.
Oh, wow.
So, in other
Okay.
words, the smaller the clot size is, the more distal the clot location, the higher is the efficacy of the IV thrombolytic agents. But once you get into large clot size, large clot burden, then the benefit of endovascular minimally invasive therapy really has made a big difference and is now proven by large multi-centered international control trials. So there are
Mhm.
multiple clinical trials. So there is this medical standard of therapy, which is the IVTPA, and then there is the interventional standard of stroke
Okay.
therapy,
Mhm.
where we put the clot out using a suction aspiration catheter or a stent retriever, and especially useful for people who have either had a surgery, such as a bypass surgery or a recent abdominal surgery, so that they cannot receive the IV medication, the blood thinner, right?
Mhm.
And or people who awaken from the stroke. So the minimally invasive therapy really makes a difference in
Okay.
those cases.
Makes sense to me. So I'm going to take it over now to a different procedure. So now we're looking at someone who's having a stroke and it is a brain bleed. And from there, once you find out that it's not a clogging stroke, I'm thinking about the ER too, what is the immediate course of action there when it's a bleeding stroke?
We're still calling our neurointerventionists to see if they can get in there and find out where this bleeding is. Now,
Okay.
that's the issue: is there something that they can do immediately for this, or is this going to be? So there's two kinds of bleeds. So there's the intracranial hemorrhage, and then there's a subdural hematoma, which is
Mm.
kind of a bruise between the skull and the brain. That
Mhm.
that also puts pressure on the brain, and that it can also affect blood flow. So two very different things. The subdural hematoma is evacuated, and that usually reduces everything. The bleed itself, we're going to call somebody like Dr. Gupta and say, okay, how do we end up doing this? Is there something we can get in there to find out where the bleeding site is? So oftentimes, if it's a bleeding stroke, we're going to refer to our neurointerventionalists.
Okay. And then, so here's the question. I remember there was a time on one of the stroke programs that if the bleeding happens inside the skull, that there's so much pressure in there that the pressure needs to be relieved. And so that would be my next question. Do you take, a part of the skull out? I mean, literally like drill a hole in the skull. I remember us talking about that to relieve some of the pressure and let some of the brain get some air. And let's talk about that. And it seems like, how do you do that? I mean, literally take some of the skull out, put it aside for a while, wait till things go back, put it back in. But how do you do that?
So although the 85% of all strokes are ischemic, as in caused by the clotting, and
Hmm.
about 15% or less are the bleeding type of the stroke, but the bleeding type of the stroke are the ones with very high mortality, or
Mm.
probability of dying. So as Dr. Berryman alluded to, one of them is this intracerebral hemorrhage, where an immediate craniotomy, as in taking the portion of the skull out to allow the brain swelling and the brain pressure to come down, is life saving. So
Mhm.
that's one of the few neurosurgical procedures that's done emergently as a life-saving measure to save somebody's life in order by reducing the pressure and amount of the pressure caused by the blood in the brain. And also the other kind of the bleeding, which is from the ruptured aneurysm called the subarachnoid hemorrhage, also required placement of a shunt, a small catheter that relieves the pressure inside the brain. So once the key thing is to stabilize the person's blood pressure and the pressure inside the brain, either by doing emergency surgical decompression or by placing in a shunt catheter. Once the patient is stable, then we take the patient to an angiography suite and we do the angiogram to find out what's the cause of the bleeding. If it's an aneurysm, the aneurysm is secured by placement of coils inside the brain. Or if it's caused by a brain AV fistula or a AVM, then we treat them accordingly.
So go back a little bit when you talk about coils inside the brain, if it's an aneurysm. Let's talk, and that's a big question too, just the word aneurysm. If there's an aneurysm that hasn't burst yet, how does one know that one might have an aneurysm? Are there always symptoms? Are there sometimes no symptoms? Even though we're talking about strokes, I feel like those are so interchanged often in the world of this area. So when you're talking about aneurysms, how does someone know that they have an aneurysm?
Great question, Catherine. In fact, most people, about 10%, the prevalence of aneurysm and unruptured aneurysm is about 10% of the population. And out of those
10% of the
10%,
population.
and then out of those 10%, a very small minority actually go on to rupture. So
Okay.
most people have brain aneurysm and they're unaware of it because they don't get any symptoms at all. It doesn't cause them any symptoms until the point, most often in presence with a sudden rupture that causes the worst headache of their lives. And often loss of consciousness, often nausea and vomiting, and that's usually a life-threatening event, and
Mm.
people present to the ER. But most of the time, if the patients have not had any kind of a head scan, either a CT or MRI, then there is no way to find that someone has a brain aneurysm because the symptoms are not there. Sometimes the brain aneurysms can cause weakness of the eye muscles, so persons can have pain behind the eyes or they can have double vision. But most of the time, aneurysms inside the brain are painless. They don't cause symptoms until the point that they cause rupture and bleeding in the brain.
Okay. So that leads me to the next question of not that there's screening, but if someone does have a crazy headache, and I'm thinking about stroke, but stroke has all these other symptoms to it. But how often is it, and maybe not often, but maybe you can think of a time or a case study, if somebody came into the ER and just had a headache like they could not believe? What is the first line there of figuring out what's happening? Is it the CT scan
It's going to be the
again?
CAT scan.
Okay.
The worst headache of
Okay.
your life is oftentimes the subarachnoid hemorrhage. That's classically how physicians describe it, as the worst headache of your life is a subarachnoid hemorrhage. So that's the thing. And the other thing that we got to remember is the cranium is a closed vault. I mean, there's only so much space that can fit in there. So once you have added fluid or added pressure, it starts to press on the brain. It can actually what's called herniate or push the brain down and stop your breathing. So you got to remember that that's why time is so important and volume is so important, because there's only so much space within the cranium
Mm.
that we can take added pressure.
And that's good to say when you were talking about, removing that little part of the skull, which again freaks me out. But here's another question: aneurysms, strokes in general. I'd like to talk about, and I should have done this in the beginning, but talk about risk factors. Who is it that's at risk for stroke and also aneurysm? I don't know if there is a risk factor for aneurysm. I think that's
There's some
mechanically
connective tissue diseases that can make you a little bit more at risk, but for the
okay.
most part, it's a weakness in the wall of the vessel. But
Okay.
um,
So in general, then, who is more at risk for stroke? Because again, just watching regular TV, there's AFib, there's this, there's that. If you're not, and I talk about AFib too, because AFib and the risk of stroke, because that is something that we hear with different medications. And that could be something that we go into or not, are the different medications. I know that's a whole Pandora's box, so to speak. But when we're talking about risk factors, what would those be specifically for strokes?
so I think for the clotting ones, you got to think of atrial fibrillation, where the heart is not beating correctly. It can form clots and send a clot out. There's other people that have hypercoagulability issues that can form clots everywhere, and then it gets past the normal systems and it gets up to the brain. That's how the clot forms.
Mhm.
The other ones are oftentimes due to hypertension. Uncontrolled hypertension is probably number one
Mhm.
for bleeding stroke. Um, Aneurysms, meaning a weakness in the wall, and now you have an increased pressure for some reason. You're weightlifting, you're doing a lot of strenuous stuff. It pops that aneurysm, and now you have a bleed. I think, in my opinion, those are probably the two big ones.
Okay. And when you're sorry, I just lost my train of thought. So we're looking at the diagnosis again. And I want to go, so risk factors, I want to talk about once someone is diagnosed and they're treated. And we talked a little bit earlier about having the arm being numb. So there are strokes, and I feel like it's not so much anymore, but I remember when I was much younger, I'm 56 now, when I was much younger, if someone's parent had a stroke, that one side of their body just wasn't going to work again. And I feel like with time and research and treatments, that's not necessarily the case anymore. And part of that is the be fast. And the other part of it is rehabilitation. And when I say that, are there strokes that are bleeding strokes more apt and or ischemic strokes more apt to not being able to rehab well? Or does one rehab better than the other? Or is that even a thing, one way or the other?
So the strokes are so heterogeneous
Yeah.
that every person is affected indifferently depending upon the stroke severity. So some people are very lucky and they have a minor stroke, also called the TIA,
Hmm.
in which essentially means that all the symptoms spontaneously reverse and the person is back to normal. And it's also called a warning stroke. That's a sign or an indication that the person is at risk for having recurrent stroke, that the risk factors needs to be addressed, that the person needs to be investigated for what's causing the mini stroke or the
Hmm.
TIA symptoms.
Hmm.
So that's a very important sign not to be ignored, but to go to the relevant physicians and figure it out, what's how to reduce the risk factors, how to be on the right medication, what's the underlying cause of a stroke. But that's going to be different in different age groups, right? So you can
Right.
have
Good point.
strokes in rare kinds of strokes in young adults, as well as the more common mundane causes of stroke, as in high blood pressure and atrial fibrillation and atherosclerotic disease.
Hmm.
So, an investigation for mini stroke leads to the proper treatment, right, in order to
Hmm.
prevent the person from having a bigger, badder stroke. And so the disability from the stroke and the recovery from the stroke also depends upon how severe the first stroke was.
Right.
So in general, the bleeding type of the strokes have very high morbidity and mortality. For example, as Dr. Berryman was alluding to the subarachnoid hemorrhage, just about a few years ago, the probability of dying from a first ruptured aneurysm was about 50%. So half of the time when people presented to the ER with a ruptured brain aneurysm, half of them did not even survive
Mm.
because that's how bad the disease was. In
Hmm.
the rest half of the people who did survive the initial bleeding event, those people went on to have further strokes from the same physiology or the worsening or having stroke in the next 2 weeks. So the outcome from the hemorrhagic kind of a stroke is usually worse than an ischemic kind of a stroke.
Mhm.
Okay.
But again, a lot of improvement depends on intensive physical therapy, the improvement in occupational therapy, the nursing care that we have made over the last decades. So that has really improved the outcome for patients suffering from ischemic stroke and hemorrhagic stroke.
How does one know if they've had mini strokes?
I think the key is when something's different.
Okay.
If your hand's not working, it's like, hey, my hand's numb and then something's not right. My speech is not right. I can't find the word. So oftentimes it's denial is what I find is people hate to say that something's not right. My writing is not correct. I
Mm.
can't come up with that word. And it's oftentimes it's a denial issue. So TIAs I often find is people just because the symptoms can go away, it's like, "Oh, it was nothing, it was a bad migraine," or they'll make up some excuse
Mhm.
rather than seeking out care. So I think it's really important for us to get the education out there for our family members and anybody else. If something happens like this, that's the time you need to initiate 911, is
Mhm.
we need to get those patients in
And
because
not think that
denial
you're just
is
blowing it out of the water,
yeah, it's
you know?
denial is probably the number one case I see with TIAs. It's like, "Oh, it was nothing. It was a bad migraine," or they'll come up with excuses rather than going out and seeking
See, I'm
care.
listening to you and I'm thinking, I've had that bad migraine day. I've had a day where I'm just like, have I had mini strokes? But and I'm joking about it, but I'm also very serious about it. As a person that you think you're fully healthy and you think, well, just for a day or two, you're just not feeling right. And you do kind of snap out of it.
Yeah.
How often does that need to happen for you to realize, okay, if this is happening more, and you said a matter of weeks, which I thought was so interesting, Dr. Kupitz. You said within, often if you have a stroke, and things are okay, you live through it, that within a couple of weeks you'll have another stroke and another stroke. How is that chain reaction happening to someone who's already had a stroke, and why?
So that's a great question again, because I think it's important to emphasize that a mini stroke or a TIA is a harbinger of a more serious event that's coming down the road unless the person gets appropriate diagnosis and treatment. So the risk of someone having another stroke is very high within the first 24 hours or within the first week after a mini stroke or TIA,
Hmm.
within the first month of having another stroke or TIA. and then within the first 6 months, and then the risk decreases as the time goes on.
I want to focus on that. That's a great point. So if you have a stroke, chances are, and we can look at percentages if you want to, but chances
Mhm.
are, and it's almost like cancer, once you get through that 5 year, you're not in the clear, but chances are a lot less you're going to have a recurrence.
Mhm.
So let's use the word recurrence in this: a stroke, recurrence, couple of weeks into a couple of months. And then if nothing has happened, an extra stroke has not happened after 6 months, 7 months, a year, not that you're in the clear, but you're less likely. Is that point? Is that what you're?
That is correct.
Okay.
So
Okay.
once about a year goes on or 2 years goes on, then the person sort of returns to the baseline risk of stroke. So again, to reiterate, the risk of stroke or risk of recurrence of a stroke is highest within the first week, within the first 3 months, within the first 6 months, and then the risk decreases as the time goes on.
So I'm going to bring that word rehab back in again. So if you're in rehabilitation for these strokes, and I'm just going to throw this out. Let's say somebody has had 2 strokes now. They've had a stroke, and then a month later they had another stroke. And let's say that one part of them, one side of them is paralyzed, is not working well. Let's talk a little bit about rehab, because I think that's so important for people not to give up on their rehab, because it really is up to them in the end. And Dr. Bruman, I'll start with you because you're kind of the first line of people who've done that. And again, you are a trained nurse before you became a doctor.
Right.
Is this something that you dealt with, and people's attitudes or people's willingness to get better? I'd like to talk a little bit about that, because sometimes it's tough. It's
Yeah, I
tough to
think
do
it's really
things.
tough, and again, I think denial is another big component of it. It's like, oh, it was a migraine, or oh, it's nothing. In Hispanic culture, there's something that people will refer to as me dio aire, meaning I was hit by air, and I think I have a palsy because of that.
Mm.
You'll see this with Bell's palsy, you see it with strokes, and it's like, no, this is a circulatory problem, or it's Bell's palsy, one of the two. But the issue is that it's a denial problem. We hate to think that something's wrong, and especially if the condition is resolved, like
Mhm.
15 minutes later, oh yeah, I can write again. Oh, it's
Right.
nothing. It
Must have
was
been nothing. Yeah.
right. So I think the denial issue is one thing. The fear factor is another, that we're going to find something. But the issue is, we are going to find something. We're going to be able to fix it or reduce your risk of having worse outcomes. So the
Bingo.
key is, don't be fearful. Get active. Come on in. Let us evaluate you and reduce your risk of having further incidences in the future.
And I'll throw out there again, calling 911. It's just better and better, better, better to call 911. Do not drive yourself.
Yeah, the whole key in fast is the T, the
Yeah,
time.
time.
Time is brain. You lose a million neurons, either neurons or glial cells that are helping you, a minute. So if you're waiting 10 minutes to call the ambulance, you've already lost 10 million neurons.
Mhm.
Okay. And the transport time and the time to get to the CAT scan. You can imagine how many neurons you're losing just in a regular fast stuff. You can lose a lot of neurons, and even if we move very fast.
Mhm.
So if you're delaying it, it causes a much bigger stroke.
Right. Yeah, that makes sense. So we talked a couple of days ago, and I'd like to bring this up. So rapid artificial intelligence. This is something that is being used or is newly being used in diagnosis. Am I
Correct.
understanding that correct? Let's bring that up a little bit.
So there's different artificial intelligence programs. We use at our place something called Rapid, and what it does is it analyzes the flow. It takes the computer analyzes it, and really tells you, hey, there's a high risk of a large vessel occlusion here. Um,
And is this a device that is like a scan type
it
of a
takes the
device,
scan
or?
material and runs it through a computer program,
Oh,
and it tells you, hey, I think this is probably going to be a high risk stroke. The advantage we have, it's a visual thing also. So we can bring it up and say, oh man, there's no flow right here. It's very, very fast.
oh wow.
It's usually pretty good. And it really helps us help determine, hey, do I need something like Dr. Gupta right away? I have large vessel occlusion. I need to get this done. Oftentimes, before the CT is even read, we'll have the results on that rapid AI. So before my
So describe to me how that works just logistically. So you go in, you have the CAT scan. From there, you're taking the readings from the CAT scan, putting it into this AI device,
correct.
and then from there, it's translating, I
Pops right
guess.
to our phones. And so we get it right on our phones and saying, you can look at it. And it also warns you, hey, large vessel occlusion, which you can also take a look at it. Hey, there's a problem with flow here. So
Wow.
it's really super fast. It's faster than our radiologists.
Goodness gracious. Okay. On that note, then, if we're looking at just different ways of diagnosing, and again, we talked about aneurysms, I'd like to talk a little bit more about AFib and just cardiology, because I know you talked about before you went into neurology, you were an interventional cardiologist. And so there's brain and there's heart, everything that has to do with blood flow. Heart attack is, blood stopping or the heart stopping because blood flow. So if we could talk a little bit about interventional neurology, yes, but cardiology too, in the area of strokes.
W- with all due respects, I did not train in cardiology, so I was never an interventional cardiologist. I
Gotcha. Okay.
started my training in internal medicine,
Okay.
and then for my love of neurology, I switched from internal medicine to neurology. I wanted to become an interventional cardiologist, but as fate would have it, I became an interventional neurologist, which is not very far in terms of principles and what we do for our
Mhm.
patients. So. Um, so um, when it comes to especially you the the cardiology neurology overlap when
Mm-hmm.
it comes to ischemic stroke,
Mm-hmm.
the atrial fibrillation, as you alluded to, is a very common risk factor, especially as we have the aging population. The older we get, the higher is the prevalence of someone having this irregular heart rhythm called
Mm-hmm.
atrial fibrillation.
Mm-hmm.
Sometimes people can feel it and they call it, my heart, I'm having palpitations,
Mhm.
and oftentimes it is silent, right? So,
Mm-hmm.
and then the strokes caused by this irregular heart rhythm again is throws up large clot from the heart, and it can go any part of the body, including the brain. So when it goes up into the brain, it causes sudden large life-threatening strokes. So it's a very common risk factor, but thankfully we have multiple medications now in order to reduce the risk of a person having a stroke from atrial fibrillation.
So when you're talking about AFib too, because I know, for example, I'm AFib, I'm also a syncope, and I also have a heart valve that doesn't behave. So I think like, oh, I'm stroke girl. Here I am. So I try to, everything that you were talking about, taking care of yourself. So heart valves involved with that. So let's talk about AFib with again clotting, and then a heart valve too doesn't allow the blood flow to be even. So throw that in there too, because the next question I'm going to ask is medications. Again, we are bombarded with pharmaceuticals. Just take this, and then you've got the disclaimer that's half as long as the commercial. And I remember one saying, if you've got AFib not associated with heart valve problems or whatever, why is a heart valve issue an issue?
Sure. So great question again. And in olden days, if we go back 40, 50 years ago, even more, we used to have a very common thing called a rheumatic heart disease, which was essentially a infection which happened in young people while they were young teenagers, right? And then over a period of many years, that infection actually affected the heart valves, and it destroyed heart valves, and people ended up having rheumatic heart disease, affecting their mitral valves. And people had atrial fibrillation and heart failure, and unfortunately most of these conditions affected young people in their 20s and 30s, and this condition just kept get worsening. So the rheumatic valvular disease used to be a big reason for people having stroke because of concomitant atrial fibrillation. That fortunately that has been reduced and is almost eliminated in modern world. But what we still have is young people who are either have the congenital heart diseases
Mm-hmm.
and have ischemic stroke, or people who have the, again, just over the period of years, they have the non-rheumatic valvular heart diseases, and sometimes they are associated with atrial fibrillation. Sometimes the atrial fibrillation is this non-valvular, as in the valves are normal but the patient has irregular heart rhythm, the atrial fibrillation. So patients or people who have valvular heart disease are at high risk because oftentimes they require mechanical valve or bioprosthetic valve, and if you have a mechanical heart valve, then that's a high risk for clotting, clot formation, and clot going anywhere in the brain.
Mm-hmm.
And they need to be on strong blood thinners. And people may not have the heart valve disease, but they can have atrial fibrillation as an independent risk factor.
So is there any, when we're looking at risk factors too, and I know I'm getting away a little bit from brain and stroke, but with risk factors such as heart valve issues, and I know you're not a trained cardiologist, I totally understand that, but fixing these issues, does that help then your chances of decreasing your risk for stroke?
Absolutely.
And that's where medications are coming. I know medications, I
Absolutely.
feel like that's so loaded that I almost want to save that till the end. But let's talk about fixing some of the valve issues and how that can help decrease your risk.
So reducing the risk of having an ischemic stroke by any means, whether by quitting smoking,
Mm-hmm. Oh,
aggressively
good. Let's talk
controlling your
about all
blood
that
pressure,
stuff.
because
Yes.
those are the low hanging fruits, right?
Mm-hmm. Mm-hmm.
And believe it or not, once the controlling the blood pressure and controlling smoking is one of the most effective, and it's a public health measure. In if we look at the reduction in smoking and then concomitant reduction in ischemic heart disease, and then ischemic stroke, that's been a huge achievement for the American Heart Association Stroke Association. So, and then, again, along the same lines, controlling diabetes, controlling obesity, your diet, lifestyle, and then obviously fixing any structural heart disease. That all those factors will reduce a person's chance of having an ischemic stroke. And taken together, obviously, our goal is to eliminate as much as possible the risk.
Okay. And so here goes. Sorry, I keep popping the microphone, but medications now. So, and I like to not backtrack, but when somebody has a stroke, and let's say it is an ischemic stroke, and now they're on some kind of blood thinners, and again, their chances are within the next several weeks or next several months that there may be a recurrence. In the world of medications, because there are so many out there, how would you help guide just people who are listening or watching, educate them on medications? Because and there's also that Dr. Google, right? You can go to Dr. Google and look at all this stuff, and they come to you with a piece of paper that has all this stuff on there, but you're the doctor. So I think that this sometimes is a great platform to talk about. Don't read Dr. Google. Go to Dr. Baruman or go to Dr. Gupta and find out what really to do.
I think all your concerns need to be sat down and talked to your physician, because you have legitimate concerns. Whether they sound way out on left field or not, your concerns are very legitimate. And if that's going to stop you from taking the medication, that's the conversation we need to have.
Mm-hmm.
Whether it's you're concerned, well, I don't want to take this because I play roller hockey and I'm falling all the time. Well, that's something for us to consider too. It puts you at a higher risk. But your concerns should be our concerns.
Mm-hmm.
And the only way we're going to be able to address that is for you to bring it to us and for us to talk to us together and decide what's going to happen. Um, I did want to bring something up about valvular heart disease
Mm-hmm.
that he doesn't see so much, but I do, is intravenous drug abuse, where they'll
Oh,
develop
okay.
vegetations on their heart, and then parts of these vegetations can flip off and give you a stroke that way. So that's another thing that is
Wait a minute,
definitely a
repeat that. I
lifestyle.
just lost you. Say that
So
again.
you injecting yourself, and it's not clean needles. They have bacteria on it, and now the bacteria now starts to form on your valve, and it
Oh
starts to
my.
grow, and it's what we
Okay.
call a vegetation. So either that part of that vegetation come off, or it can cause turbulence around that vegetation, and now you form a clot and you flip that off. So we'll see it in intravenous drug abusers, and that's the other thing that we'll see with strokes in young people is from intravenous drug
I have
abuse.
never heard about that before. And in the beginning of the program, you said something, and I'm just curious now. This is going down the rabbit hole, but you were talking about paintball. Somebody got hit in the neck. Is that right?
It was actually a paint gun. It
A
was a
paint
painter
gun.
when I was at Parkland, and the guy had set down his paint gun, and it injected and it went right into his carotid. So then he had paint that went up into his
Oh,
brain, and
okay.
it was very hard to get. We didn't get all of it out, certainly, but it's just one of those strange things. Anything that causes a lack of circulation to your brain is going to cause a stroke, whether it be a clot, whether it be lack of blood flow from low blood pressure, or in this case, a foreign body, which is paint. So
So just to follow through that, and I don't want to take too much time. So with this gentleman, you didn't get all the paint out. Was he okay? Were
he
you
had
able to
residual.
retrieve? Okay.
We were able to retrieve some of it, but I mean, paint is not like a clot where you can pull it off.
Right.
It's very
Yeah.
different. So he ended up with a pretty significant paralysis, but it's just one of those freak accidents that can happen.
Okay.
But the key is anything that blocks blood flow is going to cause a stroke.
Okay.
So,
I have a question here that I haven't brought up in quite some time. So, having a stroke and conditions that may follow that, and we're not talking about just the rehab that people would go through. Are there any conditions that may follow having a stroke? Like we know heart valve issues can lead to a stroke. Is there anything that is the other way around? Like you have a stroke, which 5, 10 years down the line, you are now more apt to get A, B, and C condition. Or is there anything like that necessarily, Dr. Gupta?
So great question. And there is often an overlap between cognitive impairment and as a result of stroke.
Okay.
So there is a condition called vascular dementia, for which essentially means that if a person has recurrent ischemic stroke, that can damage portions of the brain especially those portions of the brain that control the cognitive abilities, our ability to think and logic and reason, mathematical abilities, in addition to the motor sensory functions. So imagine a scenario where this goes back to, again, not underestimating the role of mini stroke or TIA.
Mm-hmm.
And so a person can have recurrent ischemic stroke sufficiently number of times that can result in cognitive impairment over a period of days and weeks and months if the underlying cause of the stroke is untreated.
Right.
So that sort of cognitive impairment or is a form resulting from recurrent ischemic stroke. Sometimes strokes can cause depression. People often come to our clinics
Mhm.
complaining of that their energy levels are not the same as they used to be.
Mm-hmm.
And sometimes strokes can cause personality changes, right? Irritability, etc.
That I'd like to speak about a little bit because I know I've heard about that. There are actually movies about this. So, and you're a neurologist. How does that happen? How does it change the personality?
It's because brain is the most mysterious organ on
It
planet Earth,
is,
and
yeah.
it controls not just our bodily functions, but it defines who we are, right? It defines our personality. It makes you who you are, right?
Mm-hmm.
And it makes Dr. Berryman who he is, right? So all our personalities are driven by those specific areas of the brain that makes us unique, right? It controls our dreams, our desires, our logical thinking, our
Right.
philosophy of life. So imagine that the portion of the brain that gets damaged by a stroke or a brain tumor or something
Mhm.
inflammation, right? And that can certainly lead to personality changes. People can become more aggressive or more passive, or it's all possible, and we've seen this rare scenarios play out. I'm sure Dr. Berryman has seen in his clinical practice. I've seen a few. People can have weird dreams, hallucinations, irritabilities, psychotic behavior. So a lot of things can happen, and that strokes can be one of or a sudden change in personality can be a presentation of ischemic stroke. It's rare, but it's possible.
Right.
And is it something that continues? Is it something that after a while goes, we used the word baseline earlier, can go back to a baseline? Or, and I'm sure every case is different, but in
I
general,
think it has a spectrum.
okay.
There's a matter of, you know, some people are never going to get any better. I mean, there was one person who had a big stroke. There's a classic book called "The Man Who Mistook His Wife for a Hat," talks about all these strange little strokes. And this one person had a stroke, and he always remembered his house in the same way.
Mm.
And he won a big lawsuit because it was some kind of medical problem. So he won a big lawsuit, and they told the wife, "Do not change the house." What did
Ah,
she do? She went and bought a new house. So now he's going to the restroom in the living room because
mm,
in his mind that's the bathroom.
right.
So it really depends on the person. It really depends on how much the stroke has affected. And some people will get somewhat better. Oftentimes those parts of the brain are never going to improve, and they're going to compensate. They'll work around compensations, but they will never be quite the same.
And on that note, if I remember from shows past, there's not a regeneration of neurons in the brain. Do I remember that correctly? Because people would think, okay, well, that's just going to get better once something, for the lack of a better word, and I hate to use that word, but if something dies in the brain, that's not going to come back. But then there are neural pathways. I'm looking at you because that's always interesting to me. There's a certain part of the brain that dies, for the lack of a better word, and the neural pathways elsewhere are created. Is this part of the personality thing? Is this part of after a year you're less apt to have a stroke, etc.? How does that work?
So brain is amazing in terms of recovering,
Hmm.
and even though a portion of the brain may be irreversibly damaged, but the neuroplasticity or ability of the surrounding brain neurons or brain cells to take over and compensate for the lost function is a key in recovery, right? So often people make excellent recovery because of the adjoining brain areas. We used to think that the areas of the brain that are damaged are irreversibly damaged and there is no regenerative potential. All that is changing with our understanding,
Hmm.
especially because now, as you know, that the stem cell
Mhm.
therapy is under active research and investigation, and maybe at some point in future it would become a viable option
Sure.
because we are realizing that the brain has tremendous regenerative potential.
Hmm.
So that goes back to the ability of the brain to heal itself over time or compensate for the other lost functions.
So
I
I'm
think the way to
yes.
think about that is those young kids that have strokes that,
Oh
have,
yes.
loss of a limb, and then 3 years later, they've regenerated, they've made neuronal pathways. They're not quite the same, but they have increased function. So it's a matter of, the brain does have some flexibility to it, and some ways for changing pathways. But I think the younger you are, it seems to work better in my experience.
And because you're young doesn't mean you're not going to have a stroke. And that's something
Correct.
that, people of all walks of life can have a stroke, and aneurysms too. Something could be lying there silent and you just don't know. So if
Right.
somebody is having symptoms and they're 16 years old, those are still the stroke symptoms. So get them to therapy.
Exactly.
Um, Stem cell therapy, I always like to, when we round up the end of the program, is what is on the horizon? What is new? And I know stem cell therapy, it is still, there's a lot of research, there's a lot of stuff going on, but what can we look forward to? And this is where the disclaimer at the beginning of the show matters, because whatever you say here may change in 5 years. But what do you see on the forefront when it comes to stem cell therapy? In strokes, yes, but kind of with everything.
So in stem cells, I would leave that to Dr. Gupta.
Okay, Dr. Gupta.
I don't know enough about stem cell. I think
Yeah.
the technology and the ability to get to vessels and that kind of stuff would continue to increase. Our ability to identify strokes will continue to increase, and our ability to intervene will increase. As far as stem cells, I'm just not well
Okay.
educated
And we
enough.
may not be, it was brought up and it was just one of those things I always try, and my next question is going to be what's on the forefront coming up. But stem cell, what do you know? And again, you're not stuck in anything. I know this is not your area of expertise, but what do you feel good? Do you feel like there's a lot of stuff that's happening that is going to help not only diagnose, but treat strokes in the future?
Uh, Absolutely, positively, yes. The future is bright, especially as it comes to the stroke, both ischemic and hemorrhagic stroke. Um, we could not have imagined having on our cell phone an app like Rapid or Viz AI, essentially, which
Mhm.
tells you within minutes of finishing of the CT scan, before anyone else has looked up. It's an automatic software. It's an app that's on your smartphone. So no matter where we are, we get an alert. The AI is transforming the way that we treat stroke patients,
Right.
both ischemic and hemorrhagic. So my phone gives an alert. Bing, there is a clot for seeing so and so stroke patients in so and so location. So the message is on my phone with the patient's information, with the scans for me to look up. But the AI is getting smarter and smarter
That's
in
amazing.
detecting the clots in the brain,
Hmm.
giving us the clot location, and also when it comes to ruptured or unruptured aneurysm, as in, hey, we found an incidental aneurysm in this patient, we should better monitor this patient, or what's the size of the bleeding. And exciting things coming on the loan as in the future is robotics in interventional neurology, as
Hmm.
in ability, just like other disciplines, surgery, the ability of a physician to treat a stroke patient remotely as in hundreds of miles away. So you could be sitting here at the university or at the Sierra Hospital, and the technology is available today.
Where the surgeon can be elsewhere.
The surgeon could be
Correct.
remotely located and still be able to treat a stroke patient, take a blood clot out, or treat an aneurysm in the brain using remote abilities to with or just over a wireless network. So because he can control the robot present in the cath lab from a remote location. So the technology is available. Obviously, it's in big centers
Hmm.
now, but I'm sure that over the next few years, it's going to filter down to major other
Right.
hospitals. So that's coming. The stem cells are also in clinical research, but I'm
Hmm.
sure as more promising results come in, they would translate to more patients.
All of this is amazing. So we're at like a 4 minute point. So what I want to do is stop everything. And Dr. Baruman, and same thing with you, Dr. Gupta, in a moment. Is there anything that we have not covered yet tonight that you want to cover? Strokes are so big. We can do 50 programs on strokes. There's so many offshoots.
I don't care how much technology we have, how much kind of medicine we have. The key is recognition and time.
Mm.
If you see something, get in there quickly. Because I don't care what technology we have. The longer you wait before we intervene, the more brain you're going to lose. So beyond everything else, it's time, recognition. Don't allow your grandma or grandpa to say, it's nothing. Let's get them in. Let's get them evaluated. Let's get something done.
Better be safe than sorry.
Yeah,
Just call 911.
right.
I know, and people think there's a cost to it, this and that and the other. There's nothing more
It's going to be a
expensive than a
lot
life.
costlier to be
Right.
rehabbed.
Yeah, yeah, and that too. And that too. And just living,
Yeah.
just living. Dr. Gupta, how about you? Anything that we haven't covered yet this evening that you'd like to talk about, or something you'd like to cover a little bit more?
I would reiterate some of the same things, especially the final take home message that Dr. Berman mentioned is stroke should be treated along the trauma paradigm. Just like someone is having a heart attack. When somebody is having a heart attack, the whole team for a trauma person jumps over, right? Because we know that time is of essence. So just because the stroke doesn't hurt, it doesn't mean that we have time. We have very little time to make a big difference in the patient's outcome. So that's the key. And then, we can talk about blood thinners, etc. We can go on and on, but I think we've hit upon some of the very important key take-home messages.
And the big thing too is you talked about hypertension, right? Which means high blood pressure.
Correct.
Really quickly as an ER doc, how can you lower your high blood pressure?
Well, dietary changes for sure. Okay. Exercise. Some people, it's just, you can do all the other stuff and you're going to need medications.
Yeah.
So you can try the other stuff, but the key is to monitor your blood pressure, follow up with your physician. And then if the medication doesn't sit well with you, don't just stop it. Go back and talk to your doctor about what the side effects are that are giving it to you. How can we change it? Can we move you to a different medication? And it may take 4 or 5 different medications before we find something that works for you. The key is not to just stop it, because the only person you're hurting is yourself.
Right. So have the patience to do that.
Correct.
And the wherewithal sometimes to go see the doctor. And I think that's huge. I want to say thank you again this evening. We have been talking about strokes, knowing the signs, and getting to 911, making sure that you make that phone call. If you are just now tuning into this program, or if you want to watch this again, because sometimes things go so fast. And for you guys too, there are 3 different ways that you can watch this program back. The first one is pbselpaso.org, and just go to watch and just find the El Paso Physician, the words called the El Paso Physician. Usually you can see the logo on there. And then the El Paso County Medical Society website, always a good one on there. And with all of these, by the way, you can look up different programs that have been done. If you need a knee replacement, there's information on there about knee replacements, oncology, et cetera. But EPCMS, which El Paso County Medical Society, that's .com. So EPCMS.com. Look for the El Paso Physician logo. And then also YouTube.com. So we are streaming now on YouTube. And I went on there the other day because somebody was asking me about a shoulder replacement. And I said, oh, I'm sure you can find it on YouTube. And then I hung up and I thought, oh, can you? And so I went on there, and sure enough, go to youtube.com, type in the El Paso Physician. And from there, you've got all the different programs that we've been doing. And again, we've been doing this for 26 years. So there's just about every topic that you can get on there. And I want to say a shout out to Diego and his team, because about 6 months ago, we started recording these programs. And I just feel like the microphones always work. The lights are always working. So I thank you guys very much. I'm Catherine Berg, and you've been watching the El Paso Physician.